handouts or review materials must be treated with utmost confidentiality. It shall be the responsibility of the person whose name appears therein that the handouts or review materials are not photocopied or in any way reproduced, shared, or lent to any person or disposed in any manner. Any handouts or review materials found in the possession of another person whose name does not appear therein shall be prima facie evidence of violation of RA 8293. Top-notch review materials are updated every 6 months based on the current trends and feedback. Please buy all recommended review books and other materials.
Okay. Hi, Shoppies and Shotties, and welcome to part 2 of the organ system integration for the special senses. Let's discuss some problems with the special senses, starting with vision and glaucoma. So the eye is a ball made up of 3 different layers. Inside that ball is the very special fluid, the vitreous fluid, and the aqueous fluid. So the aqueous fluid fills the posterior chamber and the anterior chamber. And you can notice that just like a water balloon, the amount of fluid inside the eyeball can exert pressure on the whole eye. Increased fluid can increase intraocular pressure. So let's focus on this part of the eye called the angle. So this is the angle. To study the process of the production and drainage of the aqueous fluid. So let's reorient ourselves. The outer layer is the cornea and the sclera, and focusing on the corner where they meet, which is this limbus, you have the middle layer comprising the iris, ciliary body, and the choroid. So the choroid has a ciliary body, which has the ciliary muscle, and it extends as ciliary processes. Note that the lens is suspended from the processes by the suspensory fibers. So the ciliary body produces the aqueous humor from the plasma, and the aqueous humor will come out of these processes, the ciliary processes. Now the secretion is influenced by the sympathetic system. And this aqueous fluid will flow from the posterior chamber and move into the anterior chamber through the pupil. Yeah, through the pupil, it comes out this way. And the secretion is influenced by a lot of different sympathetic influences. So, for instance, beta 2 receptors will activation of the beta 2 receptors will increase secretion of aqueous fluid. Activation of alpha 2 receptors, pistil naman, it will decrease secretion. And carbonic anhydrase enzyme will also increase the secretion. So the aqueous outflow or the absorption naman will occur via 3 routes. How does it get reabsorbed into the system? Now, 90% of the aqueous fluid will get absorbed through the trabecular outflow tract, which is through this trabecular meshwork into the canal of Schlemm and then the episcleral veins. And then there's a small 10% that just gets, absorbed through the uveoscleral drainage, in which it will just pass across the face of the ciliary body into the suprachoroidal space, drained by the venous circulation. And some of it will also drain through the iris. Now, focusing on the trabecular meshwork, yung 90% natin, no? This trabecular meshwork part, it's actually a sieve-like structure made of a comprehensive meshwork. So before the humor drains into the Schlemm canal, which has opening channels that connect to the episcleral veins. Yan. So dadaan mo na dito, gets through the sieve before it enters this episcleral veins. So note that the outflow process is influenced then by a lot of cholinergic and prostaglandin analogs. So it's so important to balance the rate of production and drainage of the aqueous fluid because this will determine the intraocular pressure. So what is glaucoma? Now, glaucoma is difficult to define because it encompasses a diverse group of disorders which have a common characteristic of progressive optic neuropathy associated with visual field loss as the damage progresses. So the key modifiable factor here is the intraocular pressure. Now, normally in most individuals, intraocular pressure will range somewhere from 11 to 21 millimeters mercury, averaging at about 16 millimeters mercury. And elevated intraocular pressure is generally thought of as greater intraocular pressure than 21 millimeters mercury. The normal IOP in the general population is 16, but you can also develop glaucomatous damage with IOPs less than this. And also, there are people who have higher intraocular pressures than this with normal and no damage. So we have a very simplistic understanding of glaucoma is in that persistent elevation of the intraocular pressure will cause damage to the optic nerve, causing blindness. And some features of glaucoma include halos. You have halos and cloudy cornea. Then yeah, cloudy cornea and halos. Then you can also have a feeling of pain and discomfort, nausea and vomiting, headaches. This is seen more in glaucoma caused by closure of the angle, because when we close the angle, there's an acute rise in intraocular pressure leading to acute symptoms. Can also cause peripheral vision loss. So this happens because the IOP will cause damage to the optic nerve fibers, leading to tunnel vision. And then you have cupping of the optic disc head, because as the optic nerve damage occurs, so does the amount of cupping in the optic disc head. So on fundoscopy, we're able to peek into the posterior pole of the eye, where all the nerves in the retina send their axons to bundle up and become the optic nerve. So the bundled up axons is seen as the optic disc. Yeah. There is a pale center called the optic cup inside the disc. In glaucoma, the death of the nerve fibers will cause increase in the cup size. So I think of this um, as like eating from a watermelon. So the more you scoop out, the larger is the hole inside. So parang the more dead yung neurons, larger yung cup, yung hole inside, which is seen as the cup. Yan. So let's try to talk about the drugs used in glaucoma. Note that glaucoma can be due to increased production of humor or decreased outflow. So glaucoma is usually caused by either increased aqueous production or decreased drainage. Therefore, it is pharmacologically managed by drugs that will decrease aqueous production or help increase the outflow. So remember that the beta agonists increase production. So a class of drugs that will decrease aqueous production is beta blockade. Then remember again that alpha receptors will decrease production, and so alpha 2 agonists are used to decrease aqueous production. And finally, carbonic anhydrase enzymes is also involved in producing the secretion. So inhibition of these enzymes will help decrease production. So our beta blockers include things that end in olol. So you have timolol, betaxolol, levobunolol, and cartiolol. Then you have the alpha agonists like brimonidine and alpha clonidine. Then you have the carbonic anhydrase inhibitors, which are they end in amide because they're all sulfonamide derivatives. So you have acetazolamide, brinzolamide, and dorzolamide. So drugs naman that increase the aqueous outflow are subdivided into those that either increase the trabecular, the 90%, or increase the uveoscleral outflow, the 10%. So you have among those that increase the trabecular outflow, the non-selective alpha agonists. So in general, these include epinephrine or dipivefrin, this prodrug of epinephrine, and cholinomimetics. So you have indirect cholinomimetics like pilocarpine and indirect cholinomimetics like physostigmine and ecothiopate. So when you say direct stimulators of the choline receptors, they directly stimulate talaga by actual receptor interaction. But if they're indirect, they actually increase the concentration of acetylcholine by inhibiting the acetylcholinesterase, which is the enzyme that eats it up. So indirectly, inakit niya yung acetylcholine levels kasi they inhibit the enzyme that eats it up. Um, then you have drugs that increase uveal scleral outflow, and this is the prostaglandin analog. So prostaglandin analogs, prosts. So you have latanoprost, travoprost, bimetoprost, and tafluprost. So first line are usually actually the prostaglandin analogs and the beta blockers. So most of these meds are administered topically, but there will be some level of systemic absorption. So you still must know about the warnings, no? The beta blockers kasi, because they do beta blockade, they can cause bronchospasm, hypotension, and bradycardia. So it's critical to ask for asthma before putting any of your patients on the beta blockade. Now, the alpha agonist naman, we know that they can decrease AQs and increase outflow. Um, and they can also have some systemic absorption by crossing the blood-brain barrier. So they can cause severe hypertension and CNS depression. So these are all contraindicated in children less than 2 years old. And do not give these with MAO inhibitors. Now, the carbonic anhydrase inhibitors naman are chemically related to the sulfonamides, as mentioned a while ago. And they can cause stinging and local allergy, especially if your patient has um, high allergy to sulfonamides. Cholinomimetics, these ones, in general, they're meiotics. So they're actually predominantly used in angle closure glaucoma. Um, kasi diba in angle closure, um, sometimes it's when the dilated iris, it it closes the angle around the limbus. So in those kinds of cases, you can use the cholinomimetics so that it will pull the iris away from the angle and thus the decrease the parang covering of the outflow pathway. Now the local side effects would be syempre kasi you're pulling it away, meiosis and also myopic shift. So lalabo yung mata for a while and it can also cause some level of confusion, bradycardia, and bronchospasm because it's cholinemimetic. Now the prostaglandin analogs, they can cause conjunctival hyperemia, eyelash thickening, and iris hyperpigmentation. So for some actually, this side effect is welcome no kasi hahaba yung eyelashes. So the drugs used in glaucoma can also be in combined preparation. So this is a list of some brands where you have combination already of something that will decrease the production and increase the outflow. Para din isang administration lang. So a while ago, we talked about the topical agents. Now let's talk about some systemic agents that are available. In general, you can only use the systemic agents for emergency use, no, in emergencies of glaucoma. So they can do acute lowering of the intraocular pressure in optic emergencies, or for instance, or prior to operation. So examples here include the systemic carbonic anhydrase inhibitors, which decrease the production. So these are the acetazolamide, dichlorphenamine, and methazolamide. So side effect can be paresthesias or hypokalemia. And you have the osmotic agents, no? Like mannitol, glycerol, and isosorbide, they function to draw water out from the vitreous into the blood. So side effects will be cardiovascular overload. So you drawing too much water into the extracellular volume. And so that was glaucoma. Now let's discuss some problems naman with hearing imbalance. So let's talk about the hearing tests, no? And the clinical examination of hearing loss. The clinical examination of hearing loss should differentiate between conductive and sensory neural hearing loss. So sensory neural hearing loss is an inner ear disease or when there is damage to the cochlear nerve. So Perception of sound waves through air or and bone conduction is impaired. Kasi the end of the line sensory sensation is impaired. So sounds reaching the affected ear is quieter than on the healthy side. Now what about conductive hearing loss? In the conductive hearing loss, it's more of a problem in the middle ear. So pwedeng otosclerosis or otitis media or a very severe obstruction of the outer canal with cerumen. And the air conduction from the outer ear to inner ear is impaired. However, the bone conduction is unaffected. So they will cause sounds on the affected side to appear louder. Excuse me. Now, the Rene and Weber test can help differentiate between both types. Let's start with the Rene test. The Rene test compares the air versus the bone conduction in one ear. So physiologically, sound conduction is more efficient via air than bone. So you place a vibrating tuning fork against the mastoid bone, and the sound waves will travel via bone conduction. So as soon as the patient can no longer hear the sound, you can hold the tuning fork against the ear, and the sound waves are now conducted via the air. So patients with conductive hearing loss are no longer able to hear the sound since air conduction is severely impaired. And in those cases, you can say they have a negative Rene test, meaning may conductive hearing loss. But healthy patients and those with sensory neural hearing loss, the air conduction is still intact eh. So, may maririnig pa rin silang sounds via air conduction. And so, you call this the positive Rene test. Meaning, after the bone conduction, mayroon pa rin silang naririnig. This is positive Rene test. Now, the Weber test detects the origin of the hearing loss and the possible inner ear damage. So the Weber test will compare bone conduction on both sides of the ear by placing a vibrating tuning fork medially on the patient's head. So the sound is transmitted by bone conduction. Then physiologically, the sound should be heard equally loud in both sides. Now, if the sound is heard louder on one side, you call this lateralization. In sensory neural hearing loss, the sound will lateralize to the healthy side. Kasi, meron ka ng nerve damage dito. And so, the sound is better heard on on the other side. Now, in unilateral conductive hearing loss, the sound will lateralize, mas better heard pa siya sa affected side because of more dependence on bone conduction. So, for instance, if you have a middle ear problem on the right, on the Webers, it will lateralize and you'll hear the sound better on the right. Kasi this side depends on bone conduction. So let's practice on hearing tests. Lateralization to the right on Webers could mean conductive hearing loss on the right or left-sided sensory neural hearing loss. So bilateral positive Rene means that the air conduction is greater than the bone conduction on both sides. This rules out the conductive hearing loss. So this supports the diagnosis of left-sided sensory neural hearing loss. Next, what if your Weber is lateralized to the right and your Rene is negative on the right? Lateralization of the Webers to the right will indicate conductive hearing loss on the right or a sensory neural hearing loss on the left. So a negative Rene's test on the right means that air conduction is inferior to bone conduction on the right. This is more specific for conductive hearing loss on the right. What if your Weber does not lateralize and your Rene is positive bilaterally? No lateralization on the Weber can be physiologic or either bilateral yung conductive hearing loss mo or bilateral yung sensory neural hearing loss mo, kaya wala kang lateralization. But you have your positive Rene bilaterally, which means that air conduction surpasses bone conduction on both sides, which rules out the significant conductive hearing loss. So this result means either you have normal hearing or bilaterally equal sensory neural hearing loss. Now, what if your Weber does not lateralize, but your Rene is negative bilaterally? Unlike before, the negative Rene will indicate air conduction inferior to bone conduction on both sides. So you have symmetrical conductive hearing loss. Now, what about the balance problems? Let's talk about the approach to dizziness. So, the first thing you have to do when you have a patient presenting with dizziness is to clarify the nature of the symptom. Does the patient feel lightheadedness or pre-syncope? You ask them kung nanghihina sila or feeling nila mahihimatay sila. This is due to transient reduction of the cerebral perfusion. And so, oftentimes, you your patient will feel faint, likely to pass out. Tapos it's triggered by sudden upright posture, certain situations, um, like getting up from a recumbent position, for instance, and it may be spontaneous. Can be associated with loss of consciousness. Now, this equilibrium is when you have difficulty maintaining balance. So, hindi sila makabalance properly when they're standing or walking, and symptoms are worse when they're already walking. And it's due to multiple sensory deficits kasi loss of proprioception from sensory neuropathy, pwede din from Parkinsonism. So your patient will have a history of frequent falls, but without loss of consciousness. And this is opposed to vertigo. So vertigo is the illusion of motion while you're stationary. This is associated with nausea. Your patient will feel like the room is spinning. Symptoms are worse when they do movements or changing of the position of the head, and is associated with like nausea and or vomiting. This is due to disruption of the vestibular pathways. So if you assure that your has vertigo, umiikot daw yung mundo niya. Vertigo can be peripheral or central in etiology. Peripheral can be relatively common. So it can be localized to the ear labyrinth or vestibular nerves versus something that is central. So, yung central causes can be from the cerebellum, brainstem, or the vestibular nuclei. So, inside the brain na, no? Some clues may be helpful to distinguish between central and peripheral. If you have only unilateral hearing loss and other oral symptoms, kunyari may ear pain, pressure, and fullness, this might point to a more peripheral cause of vertigo. And because auditory pathways quickly become bilateral upon entering the brainstem, a central lesion is unlikely to cause unilateral hearing loss. So, clues that it's central include double vision, numbness, limb ataxia. These point to brainstem or cerebellar involvement. So let's talk about some of the causes of peripheral vertigo. So some problems in the labyrinth. One is benign paroxysmal positional vertigo or BPPV. So these are characterized by brief attacks, no? Biglaan. Tapos it's usually less than a minute long. So it takes just about 15 to 20 seconds. Oftentimes, the provoking maneuver is a change in the head position. Nung parang nakahiga siya, tapos nag-change siya ng head position. And this occurs because of free-floating otoconia in the semicircular canals. So the diagnosis and treatment involves positional maneuvers. What about Meniere's disease? It's characterized by vertigo, plus hearing loss, plus ear fullness. And usually the attacks will last for a couple of hours. So Meniere's disease occurs because of excess fluid or endolymph inside the inner ear. So the treatment involves some level of sodium restriction, diuretics, and possibly surgical management. Perilymphatic fistula. This occurs when there is a tear in the membrane separating the middle from the inner ear. This is associated with barotrauma or surgery. And finally, the Kogan syndrome. It's actually a very rare autoimmune disease. It's a syndrome of interstitial keratitis plus abrupt onset, vertigo, tinnitus, and rapid development of bilateral deafness. So this is characterized also with systemic vasculitis. So baka your patient will have aortitis or aortic aneurysm, and the treatment of this involves glucocorticoids. Now let's move on to vestibular cochlear nerve involvement of peripheral vertigo. So because this is because of cranial nerve 8 defects. One is vestibular neuritis. Now, this is thought to occur due to a viral or post-viral inflammation of the nerve. So this can be acute, a continuous vertigo, even when the head is still. And then it will last for days. So acute onset, tapos sobrang tagal niya maglalast. Days. Um, this involves like uh, a, a spontaneous recovery, but you can help by giving them steroids. And you have to avoid giving these patients vestibular suppressant meds. So hindi lahat ng may vertigo binibigyan ng beta histine, no? Because this can impede the central compensation and recovery. So pag inflamed yung cranial nerve 8 mo, you allow it to recover or steroids. Now, what about acoustic neuroma? This involves tumor in the cerebellopontine angle. So this is the cerebellopontine angle where you have cranial nerve 7 and 8. And sometimes you can have a tumor developing there from cranial nerve 8 sheath. That's acoustic neuroma or vestibular schwannoma. So usually the presentation involves slowly progressive unilateral sensory neural hearing loss plus vestibular hypofunctioning. And then the Ramsay-Hunt syndrome, which involves herpes zoster oticus or shingles of the ear. Then you have unilateral facial paralysis, ear pain, vesicles in the auditory canal, hearing loss, and vertigo. So yan yung shingles sa dermatomes nito. And you have vestibular paroxysmia, which is a rare chronic condition where you have very brief attacks of vertigo many times a day. Moving on to the less common causes of central vertigo, you can separate it into vascular and non-vascular causes. So among the vascular causes, you can have stroke of the medulla or the cerebellum. So you have the lateral medullary or Wallenberg syndrome, and you have the cerebellar infarct or hemorrhage. And the non-vascular causes can include vestibular migraines. So ang vestibular migraines, pwede silang headache, photophobia, and then vertigo is prominent. So para siyang migraine wherein vertigo is prominent. Meanwhile, multiple sclerosis, you can suspect this if you have other neurologic symptoms of MS. So these are the causes of episodic vertigo. Among these, BPPV is the most common cause of vertigo. So to summarize, after recognizing all the different causes, when we have a patient presenting with vertigo, if you have a patient with yung recurrent episodes niya, it only lasts less than a minute, a couple of seconds lang. Then it's triggered by head movement. It's probably BPPV. So you test them using the Dix-Hallpike maneuver. Okay, we'll be talking more on this later, no? And if it's elicited by this maneuver, then you can confirm BPPV. Otherwise, then you can consider the uncommon forms of BPPV. Also, more on that later. Now, what if you have recurrent episodes lasting a bit longer, no? More on minutes to hours, and it's associated with auditory symptoms. My ear pain, my tinnitus, my ear fullness. You can consider Meniere's disease or vestibular migraines. And findings on the audiometry test will point more to Meniere's disease. What if you have a single continuous episode lasting days, and then my history to, you try to elicit a history of a viral infection, then this patient might have vestibular neuritis. And usually this will resolve in around 1 to 2 weeks. If it persists, i-work up na natin, no? So, meanwhile, continuous vertigo with an abnormal hints exam, also more on this later, will point to a more central etiology. So you need to also work these up with so the workups involves brain MRI or MRA usually. And then if the diagnosis is made, then you can work up as indicated. So now, if you have a continuous vertigo lasting for hours to days, could this be neuritis? Or could this be central? this is what the diagnostic utility of the HINTS exam. You're trying to differentiate between probable vestibular neuritis or a central etiology in a patient na may 1 to 2 matagal na vertigo. Okay, so the HINTS exam is used to diagnose vestibular neuritis versus stroke in patients who present with hours to days of ongoing vertigo and nystagmus. So basically, the clinical scenario is sobrang tagal na ng vertigo ng patient mo, and you're just trying to differentiate peripheral versus central. So the HINTS exam has three components. You have the head impulse test, nystagmus, and the test of vertical skew. So in general, before we even demonstrate it, when the head impulse and nystagmus, these can be demonstrated in patients who have peripheral problem. So peripheral yung cause of vertigo. So kahit na ilang days na siya, usually reassuring yan kasi probably peripheral lang yung problem. However, a patient who has positive test of vertical skew, this is usually found in people with central vertigo. So let's try to go through them one by one. Okay. So the head impulse test involves you holding onto the patient's skull. Then you ask them to fixate on your nose. Then you move their head back and forth, then briskly towards the center. What you're looking for is a catch-up sakad. So in a normal person, ganun yung it would be normal. And in a normal person, normal is good. As in not having sakad is good. However, the head impulse test can show a catch-up sakad that's abnormal if you have a vestibular neuritis, a peripheral problem. So, for instance, in this patient, when you move his head to the right, you can see a catch-up sakad, and this one will point to more of a peripheral cause of his prolonged vertigo. So we have another patient here, and then on the head impulse test, you can easily see his catch-up sakad. Similarly, this patient also has a peripheral cause for his prolonged vertigo. So yon, you can see the catch-up sakad when you briskly move his head. Now, in another patient naman who has already prolonged vertigo and nausea, having a normal head impulse test, meaning you don't have a catch-up sakad, is actually quite worrisome. Because maybe if you can't find a peripheral cause, a peripheral nerve problem, it probably has a central brain problem, which she did. That's why having a normal head impulse test, meaning wala kang mahanap na catch-up sakad, can be quite worrisome in a patient with prolonged vertigo. So that was the head impulse test. Now let's look at nystagmus. Now, to check for nystagmus, you ask your patient to demonstrate primary and lateral gaze. So this is a healthy volunteer which has no nystagmus, no? You ask her to look primary and laterally. So you make sure you prevent fixation because if she fixates to look at some object, it can suppress nystagmus. So you can do this by putting a plain paper there para wala siyang fixation. So in this patient with a vestibular neuritis, meron siyang unidirectional nystagmus. Again, a patient with prolonged vertigo having peripheral problem like nystagmus is more reassuring. So yun, when the patient does the lateral gaze, there's nystagmus, unidirectional nystagmus, always in one direction only. So whether he looks to the left or the right, you can see unidirectional beating nystagmus towards his left. Now, in this other patient, you'll notice that you have a bidirectional nystagmus. So these kinds of bidirectional nystagmus can be quite worrisome. So, for instance, for this patient, initially the nystagmus was beating towards the right, and then now when you look at a different gaze, it's now beating towards the left. So these kinds of findings can be quite worrisome. Maybe there's a central problem for causing the prolonged vertigo. So that was nystagmus. And finally, let's talk about the test of skew. Now, the test of skew is done by doing the cover uncover test. So you put your hand over the patient's eye, and having no vertical skew is reassuring. So in this patient, when they did the uncovering, there was deviation of the eyes. And as we mentioned earlier, having an abnormal vertical skew can be quite worrisome for a central problem in a patient with prolonged vertigo. So there's deviation on uncovering there. So to summarize, having a reassuring hints exam pointing to more of a peripheral problem, meaning nerve lang yung problem, includes having demonstrating saccades on head impulse, having unidirectional nystagmus on the nystagmus test, and having no skew. You have to have all three components to have a reassuring hints exam, meaning you can just attribute the prolonged vertigo to a peripheral cause. Any one problem, like having no saccades or having a bidirectional nystagmus or a vertical skew, will point to a central cause now of the vertigo. Now let's go to the maneuvers to diagnose and treat benign paroxysmal positional vertigo. So there's so many maneuvers, and we'll just try to brush through as many of them as possible so that you can use them in your clinical practice. One is the Dix-Hallpike maneuver. It's used to detect BPPV involving the posterior semicircular canal. Okay, so you do this maneuver to check. By doing it, you have a patient sitting upright, and you turn the head to the right side about 45 degrees, and then you move from a sitting to supine head hanging position. So dapat medyo 20 degrees under the examination table. And then you'll see it moves the orientation of the posterior semicircular canal in the sagittal plane. So the otoliths will move down and away from the ampulla, resulting in a nystagmus that is upbeating and torsional with upper poles beating towards the lowermost right ear. So this is the way to diagnose right posterior semicircular canal involvement. Now, with your patient sitting upright, sorry, continuing. Okay, the next is the supine roll test. And in here, this is another maneuver to detect BPPV involving naman the horizontal semicircular canal. So in this maneuver, the patient is moved from a sitting to a supine position, and then the head is turned to the left ear down position. As the otolith moves away from the cupula or the right horizontal canal, a left beating geotropic nystagmus develops. Next, you turn the head to the right ear down position, and a slightly stronger right beating geotropic nystagmus develops. So this moves the otoliths towards the cupula of the right horizontal canal. And then finally, you turn the head again to the left ear down position. Then you'll have a left beating nystagmus as the otoliths migrate away from the right horizontal canal. So this kind of maneuver will detect a problem in the right horizontal semicircular canal. Another maneuver is the epicanalith repositioning maneuver. So this maneuver naman is for treatment of BPPV involving the posterior semicircular canal. So the patient is moved into the right ear down position, as with the Dix-Hallpike maneuver. And then you have her lie down and then put the head 20 degrees below the table. After you induce the nystagmus and then it subsides, you turn the head 90 degrees towards the unaffected left side to move the otoliths towards the common crus. Then you turn the head and trunk another 90 degrees in the same direction. So you turn. This makes the otoliths, more of the otoliths, travel in the same direction. Finally, the patient is moved towards a sitting position, allowing the otoliths to fall out of the canals to the utricle through the common crus. So each position should be held 30 seconds until the vertigo resolves. Now let's move on to the Semon canalith repositioning maneuver. This is used for treating a posterior semicircular canal as well. So you have your patient sit bedside, then you move to the right side lying position with the head pointed up away from the involved side. So after the induced nystagmus subsides, you rapidly move the patient to the opposite side lying position. Um, this is done through the upright rapid cartwheel-like maneuver. So, ikot. So the head should stay towards the left unaffected side during the maneuver. So the otoliths continue to move towards the common crus, and any induced nystagmus is in the same direction as the initial nystagmus. Finally, the patient is brought upright, head at the neutral position again, to allow the otoliths to fall into the common crus. So each position is maintained for 1 to 2 minutes until the vertigo resolves. Next, we have the barbecue canalith repositioning maneuver. Ito naman treatment for a horizontal semicircular canal. So in this maneuver, the patient is first placed in a supine position and the head is turned towards the right involved ear kung right yung involved. This produces a right beating geotropic nystagmus. Then you turn the head 90 degrees in 90-degree steps for a total of 270 degrees towards the unaffected side. This moves the otoliths away from the cupula to enter the utricle, and during each step, the induced nystagmus should be to the left as the otolith migrates. Then you have their patient assume a sitting position. So each of these steps should be maintained 30 seconds to 1 minute until the vertigo is resolved. Okay, there's more. The Guffoni canalith repositioning maneuver similarly treats a horizontal semicircular canal problem. So the patient lie down on the unaffected left side in the sitting position. In the sitting position kasi, the otolith is in the dependent part of the long arm of the right horizontal semicircular canal. And if you lie down on this unaffected left side, you move the otoliths posteriorly in the right horizontal canal. So this causes nystagmus beating towards the left, towards the ground. So when the head is turned even farther towards the ground, the otoliths move even more posteriorly and they fall into the utricle, causing a left beating nystagmus. Then you move the patient back to the upright position. Each of these positions is maintained for 2 minutes. Okay, and that was hearing and balance. Now let's discuss some problems with smell. One is allergic rhinitis. So allergic rhinitis is associated with a symptom complex characterized by paroxysm of sneezing, rhinorrhea, nasal obstruction, itching of the eyes, nose, and palate, and it's frequently associated with symptoms like postnasal drip, cough, irritability, and fatigue. So the pathogenesis involves exposure to allergens. So Antigen presenting cells will process these antigens into peptides and they will present these peptides to the helper T cells. So from naive, the helper T cells will develop and release interleukins 4 and interleukins 13, which will stimulate B cells to produce an, um, immunoglobulin E, um, producing plasma cells. So the plasma cells start producing immunoglobulin E, and the immunoglobulin E will coat mast cells. In the nasal mucosa, they'll also coat basophils in the plasma, and these will be ready to trigger an allergic response once you meet the allergen for a second time. So once you meet the antigen on the second time, the antigen will bind to the immunoglobulin E antibodies on the mast cells and basophils, and they trigger a release, a massive release of preformed mediators like histamine, leukotrienes, prostaglandins, and kinines. And then these cause inflammation and allergy symptoms. So that's the primary reaction phase. However, we have something called the secondary reaction phase, meaning 4 to 6 hours after the primary reaction phase, these initial mediators already recruit inflammatory cells like lymphocytes, eosinophils, and basophils, causing the second phase of mediators and even more inflammation. So the stimulation of the mucous gland secretions causes rhinorrhea, and the sensory nerve stimulation causes pruritus, sneezing, and itching. Meanwhile, the vasodilation will cause nasal congestion and pressure, and the plasma exudation will cause tissue edema. So in general, you can classify them as intermittent versus persistent. Pag lumampas na yun sa symptoms more than 4 days a week and more than 4 weeks at a time. And then you can have mild to moderate, mild versus moderate to severe. Once it involves affectation of sleep, activities of daily living, difficulties at school and at work, and other troublesome symptoms. So a little about the drugs used in allergic rhinitis. Okay, so the treatment can involve localized treatment like nasal saline. In general, you can use salt water to wash mucus and irritants away from the nose. However, you have to make sure that you use sterile water for the nasal irrigation because you can have enfowlery infections causing PAM if you use problematic nasal flushes. Next, glucocorticoids. Glucocorticoids can be available as nasal sprays. So you have first generation and second generation glucocorticoid sprays. Their role is to inhibit allergic inflammation, and they can act. The onset is not immediate. It takes a few hours before effect. No, some side effects can include epistaxis and nasal septal perforation because of the thinning of the tissue from chronic use of steroids. Then you can also have antihistamine, pwedeng oral, pwedeng nasal spray, pwedeng ophthalmic drops. So the oral H1 antihistamine can have sedating first generation. So they have sedating and anticholinergic side effect. Kaya we prefer the second gen kasi they're more minimally sedating, less penetration through the blood-brain barrier, and less anticholinergic side effects. Pero meron pa din. So these have faster onset within 1 hour. So we have also nasal sprays like azelastine or lapatidine nasal sprays, which can have rapid onset and they can relieve nasal congestion. Note that azelastine has some bitter taste that can be mildly sedating. And finally, we have the ophthalmic antihistamine drops. No? So what about mast cell stabilizers? These are the other less commonly used drugs like mast cell stabilizers like cromolyn, can be as eye drops, can be as nasal sprays. Their role is to inhibit mast cell release of histamine. So they're actually quite safe, but they have low efficacy. You have leukotriene modifiers like montelukast oral tablets. The problem is they are quite associated with neuropsychiatric changes and mood changes. Then we can have the antimuscarinics like ipratropium bromide nasal spray, which can decrease rhinorrhea. And you can have nasal congestants. The problem with nasal decongestants, is that they're not recommended as monotherapy because prolonged use can cause parang reflux rhinitis called rhinitis medicamentosa. So this table summarizes the kind of preferred treatments in mild, moderate to severe with intermittent versus persistent symptoms of allergic rhinitis. So in general, if you have mild intermittent, no, you can just have yung mga oral antihistamines or intranasal antihistamines and or decongestants, sometimes just as needed kasi intermittent lang naman yung symptoms. But if you have more of intermittent, moderate to severe, or mild persistent, then you can have these first line drugs or intranasal corticosteroids na or litra. Then if they still persist after 2 to 4 weeks, then you can start stepping up treatment. Meanwhile, in persistent moderate to severe, you can already start them on the intranasal corticosteroids, antihistamines, and litra. And then you can step up if there's failure of improvement. Now let's discuss some problems with smell and taste. So smell and taste dysfunction can be a result. Dito tayo sa taste dysfunction. Taste dysfunction can be a result of local epithelial disorders, including damage to the gustatory papillae and taste buds itself. So the other problem is put it in sa neurons that you can have damage to the peripheral chemosensory units or central lesions. So let's talk about smell and taste disorders in COVID-19. So we have a lot of meta-analysis recently that suggests that there's actually quite high prevalence of olfactory dysfunction and gustatory dysfunction in patients with COVID-19. In fact, it's said that self-reported loss of smell and taste can be even more prognostic than other signs and symptoms like fatigue, fever, or cough in predicting COVID infection. So significantly, the loss of taste is consistently being reported as a common symptom of long COVID, meaning persistence of symptoms already after 4 weeks of infection. So a little about the pathogenesis. We said that the lingual epithelium is actually covered by a tongue film, which includes saliva, they have a microbiota, and other exfoliated cells there. And normally, the taste buds will diffuse through this tongue film to reach the taste receptor cells on the taste buds. Now, in COVID-19, you have dysbiosis because of the viral invasion, and they can disrupt the commensal hemostasis and induce an innate inflammatory response, no? Which can increase exfoliation. And remember, living and being replaced kasi yung mga taste buds mo, yung taste bud cells, but you have basal cells here that are constantly renewing the taste cells. So the taste bud cells, the homeostasis involving the replenishment of these taste receptors can be affected in inflammation, and so this can affect taste perception. So note here that you have oral epithelial cells that express multiple anti-receptors for SARS-CoV. Kaya that's why they can be primarily affected. What about the smell? So, a possible pathogenesis for the olfactory disorders in COVID involved infection and inflammation of the supporting cells of the olfactory epithelium, and they can lead to alterations also in the local hemostasis there. What else? They can also damage endothelial cells and vascular pericytes, leading to hypoperfusion and inflammation. So in both of these pathophysiology, you can really have cytokine release that can involve damage or affectation of the neuronal signaling. And you can also have olfactory cleft obstruction and direct infection of neuronal cells, causing problems with the smell. And so we already discussed some of the more interesting and common problems in the special senses. Thank you very much for having me. I hope you enjoyed part 2 of the organ system integration special senses.